Thank you everyone for joining today's webinar. This is the LRC's last webinar of the fiscal year. Today we are going to be talking about supporting tobacco recovery in mental health and substance use disorder and give a legislative overview from the 2026 legislative session. We are honored to be joined with Alex Nowak from the Maryland Department of Health Center for Tobacco Prevention and Control and Amanda Hill from Gaudenzia Addiction Treatment and Recovery Services. So, for today's webinar, we're going to start with Alex giving us an overview of tobacco use in behavioral health populations in Maryland. Then we will kick it over to Amanda, who's going to talk about Gaudenzia's work in supporting tobacco recovery in behavioral health and substance use disorder. Then we'll pause and do a Q&A for Alex and Amanda. And then George, me, and Kathy Hoke from the Legal Resource Center will give a 2026 LRC legislative update for both cannabis and tobacco. So without further ado, I'm going to kick it over to Alex.
Hi, everyone, and thanks, Katie. I'm really happy to be here today. So I'm just going to briefly kick us off to provide some background information about tobacco use and behavioral health populations in Maryland and why we're undertaking this work. Next slide, please. This is just the mission and vision of the Prevention and Health Promotion Administration within MDH. Next slide, please. So just really briefly, these are kind of the questions that I would like us to help frame our conversation today that we'll kind of be answering throughout the webinar. So first of all, looking at why tobacco use presents a unique and critical challenge when working with people that have behavioral health conditions, including substance use disorder. We're also then looking for how do we address this problem. So what disparities exist and what are the benefits that people with behavioral health conditions gain that are unique from receiving tobacco treatment. And then also what strategies have we at the Department of Health, as well as some of our project partners, including Gaudenzia, done to address some of these disparities. Next slide, please. So this is just a quick visual representation of kind of what the landscape looks like and a scope of the problem. So as we all know, tobacco use remains the leading cause of preventable death in the United States. There, we still want to acknowledge the success that has happened. So if we see here, over the past several decades, we've seen steady declines in tobacco use, which is definitely something we want to celebrate. But if we can still see, even though use has gone down in the bottom line, which is for people with no behavioral health conditions, and the top is people with behavioral health conditions, we've seen declines over the past decade or so across both groups, but we still see that tobacco use and behavioral health populations in US adults over 18 remains significantly higher. And the Surgeon General has noted that progress will not be made in further reducing tobacco use if these gaps and disparities between populations, including people with behavioral health conditions, aren't addressed. Next slide. This is a little bit of what we're looking at in Maryland. So just to break it down from recent behavioral health risk factor surveillance system data from 2024. The key takeaway here, and you can play it one more time, Katie, thank you. We see here boxed in red that across all categories, people that both have depressive disorder and Maryland adults that have reported poor mental health are significantly more likely to be current smokers, including those with depressive disorder, are almost twice as likely to be a current smoker than people with depressive disorder who are never smokers. And then we look at similar trends with people, poor mental health is going to also be more likely to be current smokers. Next slide. And then when we're looking at strategies and best practices to how to address some of these disparities, we like to look at what is called the three-legged stool approach. And so what this means is there's going to be a combination of medications, including nicotine replacement therapy and other medications like bupropion and varenicline that will help manage cravings and reduce withdrawal symptoms. We also like to couple that with counseling, whether it's individual or group or some type of other like behavioral modifications. And this is to provide behavioral health strategies and emotional support on a person's quit journey. And then lastly, the supportive environment. We like to look at also providing social support, such as through peers, tobacco-free policies, which is something we'll talk about today, as well as alternative activities like wellness breaks and contingency management. And we call it the three-legged stool because if you take one of the legs away, it kind of like falls down. You need all three to have the best long-term outcomes and create an environment that is going to be supportive and receiving treatment to also get help with their tobacco use while getting treatment for other conditions. And so we know that this strategy is not only work, but it yields significant public health benefits for and health outcomes. It will reduce a lot of their mental health, including depression, anxiety, improves their overall quality of life, and it also enhances their recovery from other non-tobacco substances. And from the research, we know that smokers who quit during their recovery are more likely to be in remission at 1 year from substance use disorder compared to people who did not quit. And that's by almost 2.5 times. They're more likely to be in remission from SUD compared to people who did not quit. And last slide for me, please. Great. And this is where I'll just end for now before I hand it over to Amanda. So this is just a brief overview of some of the things we're doing at the Department of Health. So we're looking at supporting behavioral health systems and providers to integrate tobacco-free policies as well as cessation services to their behavioral health clients. This includes Gaudenzia and some of our other partners. We also have with the Maryland Tobacco Quit Line a special program for people who call or enroll through any of those modalities that have a behavioral health condition. They receive additional support. And to date, we've seen over 6,000 Marylanders successfully utilize that program. And they have very similar, if not better, program satisfaction and quit outcomes than other people without those conditions utilizing the quit line. You also see here some examples of our Continue the Good campaign, which is designed for not only behavioral health providers, but just targeted media for folks who are with behavioral health conditions that are also tobacco users, and how framing it within a recovery positive message that this is a challenge for everyone, and there's support out there, and it will yield you even better outcomes for your recovery if you also include cutting back or quitting tobacco. And we also support that through training through a tobacco control resource center, who have just within the past couple of years done over 16 trainings and trained nearly 2,500 healthcare professionals in Maryland to better provide these services to their clients. So lots of exciting work, and we're going to get a little bit more info on what that works look like at the provider level. So I'll turn it over. We'll hold questions until after Amanda. And Amanda, I will go ahead and turn it over to you.
Thanks, Alex. Hello, everyone. My name is Amanda Hill. I am a nurse manager with Gaudenzia in the Chesapeake region. Today, I'm here to share our journey through a grant awarded by the Maryland Department of Health. This grant has supported our efforts to integrate and strengthen tobacco recovery within behavioral health and substance use disorder treatment. I'll walk you through how we've built and implemented this initiative, the impact it's had so far, and what we've learned along the way. Next slide, please. So a little bit about Gaudenzia. We are one of the largest nonprofit providers of substance use and co-occurring disorder treatment in the United States. Our approach is person-centered, strengths-focused, and trauma-informed, ensuring care is tailored to each individual's needs. We provide evidence-based treatment while promoting personal responsibility, recovery, and community support. The Chesapeake region, which is Maryland, includes 4 facilities: Crownsville, Park Heights, Woodland, and Owings Mills. Across these programs, we offer a full continuum of care, including crisis services, withdrawal management, residential treatment, and intensive outpatient services. Next slide, please. At Gaudenzia, we serve approximately 2,100 admissions annually across the 4 facilities in the Chesapeake region. All of the clients that we serve have a primary substance use related disorder, and many also have a co-occurring mental health conditions. Most of the individuals we serve are covered by Maryland Medicaid, and many of the clients experience chronic homelessness or housing instability. Clients often present with multiple physical, mental health, and social service needs. These complex challenges require comprehensive, integrated, and person-centered care. Next slide, please. As Alex presented some of the history with tobacco use in the SUD setting and mental health, behavioral health setting, the problem with tobacco use at Gaudenzia, it's screened that 69% of our clients at admission report using tobacco products. Tobacco use is also very common among Gaudenzia staff members. They are not asked to, provide information on their smoking habits, but estimates suggest that more than half of our staff may use tobacco products. And these rates highlight a significant opportunity to improve health outcomes for both clients and employees through tobacco treatment and cessation initiatives. Next slide, please. A little bit of background for before we got the grant or applied for the grant. Gaudenzia was primarily focused on providing substance use disorder treatment through residential and outpatient programs. While smoke-free policies existed, implementation and enforcement varied across facilities, and there were limited system-wide tobacco treatment processes such as the electronic health record updates, tobacco screening, and no existing protocols for treatment or referrals. We did an evaluation of client tobacco use, which revealed a high prevalence of tobacco use and significant tobacco-related health disparities among the population we serve. These findings highlighted the need to address nicotine dependence as part of a comprehensive recovery services. So Gaudenzia was in collaboration with the Center for Tobacco Prevention and Control and the Maryland Department of Health. The goals of the grant were to integrate evidence-based tobacco treatment into routine SUD care across all programs, make tobacco cessation a system-wide priority rather than just a separate service, standardize policies, protocols, and practices across all facilities, train staff to become tobacco treatment facilitators, implement the Freedom from Smoking curriculum to support clients interested in quitting, and achieve fully tobacco-free programs across the Chesapeake region by June 30th of 2026. Next slide, please. So the project overview, the Tobacco Recovery Project is a collaborative effort involving clinical staff, medical, and recovery support staff, along with community partners such as the Maryland Department of Health, the American Lung Association, local health departments, and the Maryland Quit Line. As part of the project, 25 staff members were trained as Freedom from Smoking facilitators to provide evidence-based tobacco cessation support. The project focuses on creating healthier, tobacco-free environments, expanding access to cessation services, and standardizing tobacco screening and referral processes across programs. This grant was a 3-year grant initiative with the goal of achieving fully tobacco-free programs by June 30th of this year. The project is being implemented across Gaudenzia's Maryland sites, which are serving Baltimore City, Baltimore County, and Anne Arundel County. The primary purpose is to reduce tobacco-related health disparities, integrate tobacco recovery into substance use treatment, and create a culture that supports whole person recovery. Key strategies include developing tobacco-free policies, improving data collection, implementing standardized screening and referral protocols, and training staff to deliver the Freedom from Smoking curriculum. Next slide, please. So to build internal capacity, we recognize 25 staff members to be trained to deliver the American Lung Association's Freedom from Smoking curriculum. The plan was to update organizational policies and protocols to support a consistent tobacco-free approach across all programs. A standardized tobacco use disorder or TUD screening process was created and implemented to identify tobacco use and treatment needs early. Expanding access to evidence-based treatment options, including nicotine replacement therapy or NRT, such as nicotine patches and nicotine lozenges, as well as medications like varenicline and Wellbutrin. Educational materials, signage, and resources developed to increase awareness and provide ongoing support for both clients and staff were to be created. Tobacco recovery education was also being integrated into therapeutic programming through dedicated groups focused on tobacco use, health impacts, and cessation strategies. Next slide, please. So through this tobacco recovery project, our policy did change. And as part of the project, Gaudenzia strengthened and standardized tobacco-related policies across all Chesapeake region facilities. The number of daily smoke breaks was reduced from 8 to 4 to support healthier behaviors and reduce tobacco use opportunities. Staff are no longer permitted to purchase tobacco products for clients or conduct store runs for tobacco-related items. Smoking is prohibited within 25 feet of any building entrance, and signage has been installed to reinforce these expectations. Designated smoking areas were established to ensure compliance with the updated policy while maintaining safety and consistency. For those clients choosing not to use tobacco products, alternative activities and supports were introduced, including outdoor recreation and items such as lollipops to help address oral cravings. This is part of our contingency management. To maintain professional boundaries and support a recovery-focused environment, staff are now prohibited from smoking alongside clients during their breaks. Next slide, please. Excuse me. For tobacco use disorder treatment, Gaudenzia offers evidence-based treatment options to support clients who want to reduce or quit tobacco use. Available treatments include nicotine replacement therapy such as patches, lozenges, as well as prescription medications like varenicline and Wellbutrin when clinically appropriate. Varenicline and Wellbutrin are typically initiated after clients have completed the detox process. To improve access, clients receive their own supply of NRT through our pharmacy provider. And for clients without insurance coverage, NRT is available for them through our grant-funded resources, ensuring treatment is accessible regardless of financial barriers. Another thing that is super important in tobacco use disorder treatment is group education. Education is a key component of the Tobacco Recovery Project. The American Lung Association's Freedom from Smoking curriculum is used to provide clients and staff with information about tobacco use disorder, health risks, and cessation strategies. Tobacco use and treatment options are regularly discussed in medical and therapeutic groups across our facilities. These conversations help to normalize tobacco recovery as part of overall recovery and encourage clients to explore quitting when they are ready. Next slide, please. So our workflow changed with this project, And now every client is screened for tobacco use upon admission to identify tobacco use disorder and early treatment. For those clients who screen positive, they are immediately educated on tobacco use disorder and offered nicotine replacement therapy and or other smoking cessation medications if they are interested. Education about tobacco use and treatment options is provided throughout their entire treatment episode, which includes at admission, during ongoing care, and again at discharge. So if a client comes in and is a smoker and originally does not want to accept NRT or other cessation medications, they have options to start at any time they wish throughout their length of stay. And all clients leaving treatment are referred to the Maryland Quit Line to ensure continued support after discharge. Standing medical protocols were established to allow NRT and other cessation medications to be initiated at admission or any point during treatment when a client is ready. Our providers here in the Chesapeake region collaborated and came up with appropriate protocols that were safe for nurses to initiate immediately. Therapeutic groups are held at least 3 times a week using the Freedom from Smoking curriculum to support skill building and behavior change. At discharge, all clients are rescreened to evaluate progress, including whether they reduced or stopped tobacco use during treatment. Next slide, please. This tobacco recovery project over the last 3 years and all the work that we've put into it had a significant impact on our population. Since our electronic health record system was updated in October of 2024 to capture more accurate data, with the exception of a few months when we tried to move to a flow sheet, we've been able to better measure the reach and effectiveness of tobacco recovery efforts. A total of 1,927 clients were screened for tobacco use at admission, ensuring early identification and intervention. Approximately 750 clients received NRT and or other tobacco cessation medications during treatment. All of the clients engaged in treatment received structured education on tobacco use disorder through therapeutic groups. At discharge, just a little over 1,200 clients reported either quitting or reducing their tobacco use while in treatment. The updated tobacco recovery policy now applies across all Chesapeake region sites, covering both clients and staff, so it is now standardized throughout the whole region. And more than 50 staff members have been trained to deliver tobacco use disorder education using the American Lung Association's Freedom from Smoking curriculum. This includes a variety of nurses, counselors, peer support workers, program directors, and clinical directors. Next slide, please. So there were a couple lessons that we learned throughout this project. And one of the first lessons that we learned is that the American Lung Association's Freedom from Smoking curriculum was originally designed for longer-term settings. So we adapted it to a shorter version that better fits higher levels of care and shorter lengths of stay, which is what 2 of our facilities have higher levels of care, and clients aren't, could only be there for 21 days or less. The ALA's original curriculum was an 8-week STEP program, and by adapting a shorter version, we were able to better meet clients where they were. So we used all of the base curriculum from the ALA. We just created a shorter group didactic version of it. Early efforts to become fully tobacco-free showed that client readiness is a critical factor. Some clients expressed concerns threatened to leave treatment or said they would avoid Gaudenzia programs if we were to be tobacco free. This led to a shift in language and approach from tobacco free to supporting tobacco recovery. When smoke breaks were reduced from 8 to 4 per day, some clients found alternative ways and times to continue smoking, highlighting the need for ongoing monitoring and engagement rather than policy change alone. We learned that nicotine gum was not a practical or effective option in a large residential setting, which led to greater reliance on other forms of NRT. So we mainly use patches and lozenges because the gum ends up places where it is not the trash can. And a key factor in success has been staff buy-in. Implementation works best when staff are engaged, trained, and part of the change process rather than simply receiving top-down directives. Next slide, please. Looking ahead and next steps for this project. All Gaudenzia facilities in the Chesapeake region will continue to strengthen and sustain efforts that support tobacco recovery as part of routine care. Tobacco use screening will remain a standard part of the admission process to ensure early identification and intervention. Education on tobacco use disorder will continue to be provided consistently throughout treatment to support informed decision-making and recovery. Clients will continue to have access to nicotine replacement therapy and other smoking cessation medications with the option to start treatment whenever they are ready. All clients discharged from care will continue to receive referrals to the Maryland Quit Line to support ongoing recovery in the community. And tobacco-related policies will continue to be refined and further defined to support consistency, sustainability, and alignment across all programs. Next slide, please. I want to thank you all for taking the time to attend this presentation and learn more about the Tobacco Recovery Project. I appreciate your engagement and interest in this work to support tobacco recovery within substance use treatment settings. If you have any questions or would like additional information, please feel free to reach out. My contact information is listed below, and I welcome follow-up conversations or collaboration opportunities. Thank you again for your time and for your commitment to supporting recovery-focused care. And I will turn it over for questions.
Thank you so much, Amanda. That was awesome. I know I learned a lot. So we are going to open it up for questions for attendees of the webinar. Feel free to put any questions in the Q&A or the chat, or if you are able to come off mute, you can do that as well. While we wait for people to think about their questions, I know I have one. So I'm curious, Amanda, when you guys first implemented these policies and this effort, did you get any pushback from the staff and the clients at the beginning of this?
Yes, we did. One of our first policy changes was reducing smoke breaks from 8 a day to 4. And there was a lot of pushback. Clients threatened to leave if they couldn't smoke when they wanted to smoke. We found that a lot of clients would smoke in their bedrooms or bathrooms, which is against policy, so we had to support them behaviorally, in that process. And staff also gave a lot of pushback because a majority of the frontline staff, that the recovery support staff that work the floor and directly with the clients, they do smoke, and they would smoke with them during their fresh air breaks. And when we did not allow them to smoke alongside the clients anymore, there was pushback.
Thanks for sharing that.
I have a question, Katie. Is that okay?
Yeah.
Amanda, I'm curious about whether any peer organizations, like I know you're a leader in the field in this space. That's why you're on this call. But where are others in this space? Have other organizations called you to learn from you, excuse me, about how to, accomplish the incredible, accomplishments that you've attained? I'm just curious, like, where do you feel like Gaudenzia is in the big picture?
So nobody has really reached out to us to see what we're doing. However, earlier on in the project, we did collaborate with a provider from Shepherd Pratt and learned about their, you know, the way that they went smoke free. They went smoke free completely. But Shepherd Pratt is a different setting than we are. Um, Shepherd Pratt, like you go in and you can't just walk out. So having it be non-smoking, that's just is what it is,
Yeah.
it's non-negotiable. But here at Gaudenzia, where we have allowed smoking for so long and, you know, trying to go tobacco free was just it was a risk to losing our, half of our senses.
Hmm.
So we had to reframe that from tobacco free to supporting tobacco recovery. And we have seen success with supporting tobacco recovery. I mean, I have several clients at my location where I'm mainly at in Owings Mills, come to me and say, "Hey, Amanda, I haven't smoked a cigarette in 10 days or 20 days or a month." So, um, it is meaningful work that we've done, but nobody has reached out to us to see, the steps that we've taken. But I'm happy to meet with anybody in the future.
I was going to say that might change after today
Yeah,
because I suppose that's why Alex asked that we have you join us because I do think there are a lot of lessons to be learned, but the confidence, that others can have that it can work because you did it.
yeah.
I don't see any other questions, so I think we are going to move on to the LRC's portion of this webinar, which is to give a legislative update from the 2026 legislative session. So here's some more information from Gaudenzia if you are interested in that. Thank you again, Amanda, for joining us and giving us these insights. And I will turn things over to George Townsend now to start us off with the cannabis portion of our legislative update.
Good afternoon, everybody. Thanks for that intro, Katie. Yep, I'm George Townsend. I've got a quick update for everybody on some of the key cannabis bills from this legislative session. There were probably on the order of 15 to 25 total bills we tracked this year that mentioned cannabis. Some of them were not particularly significant or didn't really get very far in the process. But there were three very important bills we were tracking this year. I guess we'll say four because the cannabis advertising, there were kind of two versions of it that we were following. So I'll go through those very quickly just to provide an overview of what happened with them. And then if you have any questions, I'm happy to answer those at the end. So to get started, one of the biggest issues we've been tracking in the Maryland General Assembly, really since adult use cannabis was legalized 3 years ago, has been cannabis advertising, because Maryland has historically had very strong protections around cannabis business advertisements to prevent young people from being exposed to high amounts of very appealing ads. There's a lot of research showing that exposure to cannabis ads during adolescence leads to higher rates of cannabis use and higher rates of cannabis use disorder. So one big issue that we have seen pushed every year for the last 3 years, at least, has been an attempt to repeal Maryland's outdoor advertising ban. So cannabis businesses cannot use billboards or posters or any other outdoor advertisements to promote their products. And one of the two advertising bills we saw this year was HB 1519. That bill would have allowed for outdoor cannabis ads, and it also weakened a lot of the language concerning ads that target underage individuals. And it also would have weakened the safety requirements we have for ads that make claims about health benefits of cannabis products. So there was a lot in this bill we didn't like, specifically outdoor advertising being the main thing we were concerned about. And thankfully, that bill did not pass. So HB 1519 did not make it through the legislative session. It did die. And we see that as great because, again, that outdoor advertising issue is one of the key topics we've been concerned about for the last couple of years. However, there was a different advertising bill that was filed in the Senate this year. So that was Senate Bill 594. This bill did not say anything about billboards or outdoor ads, but it did have some of the same issues with HB 1519 about weakening the language around advertising to underage individuals. Specifically, Maryland says you cannot, we have sort of general prohibition saying you cannot directly or indirectly target underage individuals. And then there's a long list of specific things that advertisers can't do. Like you can't use cartoons, you can't use mascots, you can't show underage people in your ads. And unfortunately, what this bill does is it took that big sort of general prohibition and it changed it so that instead of saying we cannot directly or indirectly target underage people, it changed it to say you cannot directly target underage individuals. So taking out indirect targeting. However, I think it's important to emphasize that nice long list of specific problematic elements like cartoons and mascots and underage people, that remains untouched. So thankfully, a lot of the strongest protections in our advertising laws remain in place, although it is concerning and a little bit upsetting that general language was changed to make it a little bit weaker. I think it remains to be seen how that change is going to work in practice. I think that's something that was not made very clear during the hearings on this bill, but it's something we're going to continue to track as that law goes into effect. But that sort of slightly less problematic advertising bill, but still partially problematic advertising bill did pass. So that's advertising. Let's go to the next slide. Another big bill, this is an issue that has also come up several times in the last couple of years. And this year, a version of this bill did pass, and that is employment protections for medical cannabis users. In this case, in the case of the bill that passed, for firefighters and emergency rescue personnel. So in other states around the country, when they legalized cannabis, they passed laws essentially saying that if a person is a medical cannabis user and they're using cannabis at home in their free time, that cannot lead to any sort of adverse workplace action like firing being the main one, or like being put on suspension or having their work hours reduced or anything like that. Historically, Maryland has not had any protections like that. So generally speaking, up to this point, if a person in Maryland uses cannabis at home in their free time, and then when they go to work, they test positive for cannabis use, their employers could choose to fire them or put them on suspension or whatever the employer wants to do based on that drug test. This is the first employment protection that has been passed in the state of Maryland. It applies just to firefighters and emergency rescue personnel, so a very small part of the overall employee pool of the state of Maryland. It prohibits them from being fired or disciplined based solely on their status as a medical cannabis user. However, this is very important, it does not allow them to consume cannabis on the job, and it does not allow them to show up to work impaired or under the influence of cannabis. So it's very clear. What is protected here is medical cannabis use outside of work, not cannabis use on the job, because that would be a big problem. This version of the bill did pass. Again, it's only a very small percentage of Maryland's employees who are firefighters and emergency rescue personnel. This is something we might see future versions of a bill like this covering other industries or other employees as well. All right. And then next slide. Last but not least, I put this bill at the end because it didn't pass, thankfully, and also because it was filed very, very late in the legislative session. This is Senate Bill 1008. This is a bill that would have allowed cannabis beverages with less than 5 milligrams of THC to be sold in alcohol retail stores. So currently, any intoxicating cannabis product can only be sold in licensed dispensaries. And our entire sort of public safety infrastructure around cannabis tracking, cannabis testing, cannabis advertising is all focused on these dispensary businesses. This bill would have taken some amount of intoxicating cannabis products, specifically beverages, and put them in a completely different retail environment where they would not be subject to, seed to sale tracking, where access to the stores is not age gated. Underage people can't buy alcohol, but they're allowed to go in alcohol retailers. And it would be, these sales would be handled by people who are not familiar, who are used to selling alcohol products and are not necessarily familiar with the effects of cannabis products. So there were a lot of issues with this bill, a lot of very obvious issues with this bill. There is a portion of the bill, it did say local counties and Baltimore City would be able to they would have to opt in. So local governments would have control over whether they allowed this type of sale in their jurisdiction. But still, on the chance that any localities do opt in, that would be a huge issue, right? And then another sort of smaller issue with this bill, another thing it would do is it would divert the tax revenue for all cannabis beverages, whether they're sold in alcohol retailers or dispensaries. All the taxes would have been diverted into the Maryland General Fund, so they would no longer be supporting things like the Cannabis Public Health Fund or the Community Reinvestment and Repair Fund or local jurisdictions. All the things that we have, as a state, decided that the cannabis tax should fund would not be funded by these beverages. So there were a lot of issues, big and small, with this bill, and we're very glad it did not pass. We are going to watch to see if it comes back next year. One big issue with the bill this year is it was filed super late, so it never really had a chance to get on its feet. We are watching to see if this bill is filed normally next year. But even if it's filed on a normal timeline, it's still a bad bill. So, all right, that's all of my bills. I do really want to, just because we're doing an update here, I'm going to real quick talk to you about something many of you have heard about, which is not state law, it is federal law. If you have Googled cannabis news at any point in the last 2 months, you have certainly heard about this. So what happened back in April is the acting attorney general issued an order immediately rescheduling all state legal medical cannabis products immediately to Schedule 3 under the Controlled Substance Act, whereas for the past 50 years, cannabis had been Schedule 1, the very highest level of control, absolute prohibition. So what does it mean for medical cannabis products to be scheduled to Schedule 3? The short answer is it's not immediately clear. Certainly for like ordinary people who are ordinary cannabis users, there's no change. Rescheduling from 1 to 3 does not mean cannabis has been legalized federally. It means there may be avenues for certain businesses to sell cannabis legally at some point, but that certainly isn't what has happened yet. And so you should not consider rescheduling of medical cannabis products to be sort of immediate federal legalization or anything like that. There were really only 2 issues that were addressed in the Attorney General's order. One is that cannabis researchers, so like universities or other labs that do clinical trials with cannabis, will have a streamlined streamlined methods to access cannabis products, which is very good. It means that we will hopefully soon be getting more research, more robust, peer-reviewed studies on the effects of cannabis use, the harms of cannabis use, the potential medical applications of medical use. Hopefully, we should be getting a lot more data on that as that process gets easier, because historically it has been very hard. The other issue that was addressed in the Attorney General's order was tax benefits. That's largely out of our purview as a public health organization, but it's basically the focus of a lot of the order was how medical cannabis businesses can get tax benefits for their products. Down the line, rescheduling could be very significant as other federal agencies change their policies around it if they choose to. So that's something we're going to track. There are also going to be a lot of lawsuits, and it's certainly well above my pay grade to guess how those are going to turn out. But there are a lot of different ways that federal rescheduling could go. So watch this space and watch the federal court orders over the next, I don't know, half decade to see how this all shakes out. One last note, the only thing that was rescheduled by order was medical cannabis. There is a larger movement to reschedule all cannabis, but that has to go through a administrative hearing in the DEA, and that is going to start next week. So on June 29th, there's going to be a hearing. You could probably, I don't know that they've dropped a link to watch it yet, but there will probably be some sort of live feed of that hearing process if you're very bored next week and you want to watch people argue about cannabis. But anyway, that's all this to say. There's a lot that we don't know. There's a lot that we will be learning soon, and there is a lot we will be learning over the next couple months and years. So again, watch this space. With that is all I have. I will turn it over to Katie.
Thank you, George. So for tobacco legislation, the only widely applicable bill that did end up passing this legislative session was Senate Bill 249. This is about requiring an additional license for retailers or others who are manufacturing or distributing electronic smoking devices. So this legislation requires any entity that manufactures, distributes, or sells electronic smoking devices to obtain a separate license. It removes the provision that would have allowed or previously allowed cigarette or OTP licensees to manufacture, distribute, or sell electronic smoking devices under their cigarette or OTP license. There is no fee for the separate license if a retailer or other entity already has a cigarette or OTP license. If they do not have that license and they're just looking to obtain this electronic smoking device license, I believe the fee is $300. So this will allow current license holders to continue operating until their license expires. The bill actually becomes effective on October 1st, 2026, and it did pass. It was approved by the governor, so it is now a chapter law that can be located at Chapter 415. And the other bill that is relevant to tobacco in Maryland that passed is Senate Bill 279, and this is a Baltimore City local bill. So this bill requires applicants in Baltimore City to obtain a local licensure authorization from the mayor and city council of Baltimore City before applying for an initial or renewal county license to sell cigarettes at retail, to act as an other tobacco products retailer or tobacconist, or to act as an electronic smoking devices retailer or vape shop vendor. I think it's important to highlight this even though it's only applicable in Baltimore City, because Baltimore City has a unique issue with proliferation of tobacco retailers. And so although they don't possess the inherent authority to regulate the licenses of tobacco retailers with their local legislative powers, it's a unique way that they went back to the state legislature to get some authority to do this, to deal with that problem. So the bill prohibits the issuance of new licensure authorizations for tobacco retailer applicants for 1 year. So from October 1st, 2026 to October 1st, 2027, there will be no new licensure authorizations. And the bill does clarify that Baltimore City enforcement officers have inspection and enforcement authority. This was also approved by the governor, and it is a chapter law now that can be located at Chapter 387. And I will turn it over to Kathy, who's going to talk to us a little bit about the Premium Cigar Lounge Act that was introduced this year. And although it ended up failed, it's an interesting discussion to be had. So,
Thanks, Katie. And just on the Baltimore City bill, I'm meeting with some folks from Baltimore City on Friday as they're preparing for implementation of that bill. So it'll be an interesting kind of pilot project to have some local control over retail tobacco licensing in Maryland. So stay tuned on what that looks like. But thanks on what we keep calling the cigar bar bill, or the Maryland Premium Cigar Lounge Act of 2026, really came as a result of, in 2024, the legislature, well, for years, the legislature kept getting requests to allow a cigar bar here or a cigar bar in that county, or to allow this establishment. And then we would hear complaints. These places exist and they're allowing, they're selling alcohol and allowing indoor smoking, and, they don't meet the definition of a, tobacconist in the code or what have you. So it's been a long time coming. But in 2024, the legislature created a work group to study this question of whether, how, and when Maryland would allow indoor smoking and indoor consumption where there's alcohol being sold or consumed. And so the work group had a 2-year kind of stint till its report was due. And during that time, there was a moratorium on the issuance of alcohol licenses to tobacconists in an attempt to design, so that there were no additional licensees on the market where there was alcohol and smoking in the same place. So that's a little bit of the history. Unfortunately, the legislation as it went in originally as HB 766 and SB 623 didn't really conform to the work group report, which was actually pretty thorough. MDH led it administratively. There was engagement with industry, etc. However, the bill that went in did not really reflect the work group. So that was its first kind of frustrating aspect of it. But it also just didn't, it created more problems than it would have solved. So if you actually click on this bill link and you go to the bill page, you'll see just massive amounts of amendments that occurred as the bill was working its way, frankly, through the Senate. So the House was kind of waiting to see what the Senate would send over. And you'll see a very, very different bill to in the Senate at the end of what actually got voted out and sent over to the House from the Senate. There are some details that we have on the slide here. They're kind of irrelevant because this bill didn't pass. And I know that next year we're going to start kind of, I think, with a clean slate. But essentially, it would have allowed for a particular type of alcoholic beverages license for places that sell premium cigars, where that is, the primary business that they're in. It really defined it as 70% of the business is the sale of premium cigar products. And so we wouldn't have this concern of what does incidental mean, like in the current code. So there was a harder definition of where we would cut them off, some limitations on where they could be, so that children in childcare facilities or people visiting medical healthcare facilities would not be exposed to secondhand smoke through shared wall, shared ventilation systems, and the like. But the bottom line is the bill didn't pass. It just, again, by the end of it came to be hot mess is all I can think of as the best description. What we do know is there will be a bill in 2027. Of that, I'm certain. I don't know who will put it in, but it'll be in. Unfortunately, until then, that moratorium that had been issued while the work group was kind of in session has expired. So, expires next week on July 1st. And so there is not a limitation on the issuance of alcoholic beverages licenses to tobacconists. It doesn't mean, and I actually don't think it means, that we're going to see a proliferation of these establishments. But one of the factors they always consider in legislation is grandfathering in existing licensees. And so there may be a move for people to get in and allow this activity so that when there is a grandfathering in, they're included. Because limiting the number of licenses has been critically important, I think, to everyone, to the folks in the industry, to the folks in the legislature, to the folks on the public health side of things. So that's just a little concern that we have about the bill not passing, but something new will come in. The other kind of the rest of the story, if you will, for those of us old enough to remember what that is that local jurisdictions with home rule powers do have the power to adopt hardier provisions than the State Clean Air Act, right? So there's a non-preemption clause, meaning locals are not preempted and they retain their existing local powers. So if a jurisdiction was concerned about a premium cigar lounge act passing in 2027 that's too liberal in allowing premium cigar shops to have drinking and smoking, or that's not something the county is interested in, the county can take local action now, so that that would be in effect, and the state would not override that. Again, there has always been this non-preemption of local jurisdictions. And so if you think your county would be interested in making sure they don't have a problem or a bigger problem, if you already have some establishments, there are ways to kind of grandfather them in, but not allow new ones. Just reach out to the LRC. We are helping 2 counties right now who have reached out to us to help with this, because if there is a ground swell of support for that, I think it's going to speak really to the legislature and how narrow, if they pass something, how narrow that really needs to be. So thank you for giving me a couple of minutes, Katie, and I'll turn it back over to you.
Of course, thank you for that, Kathy. We always appreciate your thorough insights. So our final slide here is just, if you have any questions, feel free to reach out to one of us. Our email addresses are here, or we have an email address that goes to everyone at the LRC generally. But also feel free to come off mute, put any questions in the chat or the Q&A. We will address them with the time that we have left. And I just wanted to highlight the LRC resources. If you ever have any questions about any legislative provisions that happened in previous legislative sessions, or are looking for any information in the cannabis or tobacco policy space in Maryland, our website has lots of really great resources on it. And then we also have a LinkedIn page where we put out pretty recent updates about things that have happened federally, locally, at the state level, whatever it may be. We try to keep our partners updated through our updates that we post on that page. So please follow us. We would love to share that information with you. And thank you again to Amanda for sharing her insights with us, and Alex for being here with us as well.